Hello, y'all. We have made it to week 10. It's our first week of 2 weeks talking about MDMA. So the way that the class is outlined, we've talked about psilocybin for 2 weeks. We'll talk about MDMA for 2 weeks. We'll return to psilocybin, then talk for 1 week about ketamine. And then we'll talk about just some broader implications and things to think about in the field at large about psychedelic assisted, MDMA assisted, and ketamine assisted psychotherapy. So let's talk about some protocols and phase 3 evidence for MDMA. So our first reading introduces MDMA assisted psychotherapy as an emerging treatment model that combines a psychoactive substance with a structured psychotherapeutic process, aka MDMA assisted psychotherapy. One of the most important points in the chapter is that MDMA is not being studied simply as a medication in the conventional psychiatric sense. Rather, it is being studied as a catalyst that may enhance the therapeutic process itself. The authors frame this as a part of a broader reemergence of psychedelic assisted treatment after decades of political and regulatory suppression that we've talked about at length in the class. This chapter also moves across multiple levels of analysis. It reviews the history of MDMA, the neuropsychological and subjective effects of the drug, findings from clinical trials, and the actual therapeutic method used in the MAPS-sponsored studies. So MAPS is a multidimensional association for psychedelic studies based out of California. It's been rebranded as Lycos, and now I think it's back to MAPS because MAPS took to the FDA MDMA assisted therapy as they were looking for FDA approval. They took decades of research with them, and they did not gain FDA approval. So that was a huge setback in the psychedelic assisted psychotherapy movement. And they are back at it, sponsoring studies. They needed to kind of recalibrate, but just letting you know like where they're at. So it is likely that the first substance of that's a psychedelic substance that will get FDA approval is probably going to be psilocybin, but we'll see. Okay, so it also highlights regulatory barriers, ethical considerations, and broader implications of MDMA-assisted psychotherapy for the future of psychiatry and psychology. So for you, this chapter is especially important because it illustrates how psychedelic-assisted psychotherapy cannot be reduced either to pharmacology alone or to psychotherapy alone. Instead, it is presented as an interaction among drug effects, therapeutic method, and the relational field created by therapists and participants. So the central premise of this chapter is that MDMA-assisted psychotherapy represents a different kind of psychiatric intervention. The authors are clear that these are not simply drug trials. Instead, the treatment model assumes that MDMA may create a psychological and neurobiological state that makes psychotherapy more effective. They identify 3 core interacting elements. First, the direct effects of MDMA itself. Second, the structure and method of psychotherapy. And third, the quality of the therapeutic relationship. This means that outcomes are not thought to arise from the drug alone. The medicine may open a window, but what happens within the window depends on the therapeutic setting, the participant's process, and the therapist's capacities to support that process. This is a major conceptual shift from conventional psychiatry, where medications are often expected to reduce symptoms more directly and independently of relational context. The authors are suggesting that MDMA may help catalyze healing by enhancing access to an intrinsic healing capacity within the person. That idea is both clinically compelling and theoretically provocative. The history of MDMA is important because it shows that current clinical research did not arise in a vacuum. MDMA was first synthesized in 1912 and patented in 1914, but it was not developed medically at that time. Human use did not begin until much later. In the 1970s, MDMA began to spread along 2 tracks. One track involved psychotherapists who used it as an adjunct to psychotherapy. The other track involved growing non-clinical or recreational use. The chapter notes that some therapists found MDMA especially valuable for reducing defensiveness, increasing emotional openness, and facilitating self-exploration. Alexander Shulgin and Leo Zeff are highlighted as especially important in helping move MDMA into psychotherapeutic contexts. During this period, therapists were intentionally quiet about their use because they feared criminalization. That fear turned out to be justified. As public awareness and recreational use increased, government attention intensified, setting the stage for MDMA's scheduling and the abrupt end of legal therapeutic use. The scheduling of MDMA is one of the key political and ethical themes of the chapter. In 1985, despite expert testimony that MDMA had therapeutic potential and could be safely used in controlled settings, the DEA placed it in Schedule 1. Importantly, the administrative law judge who heard the evidence recommended Schedule 3 instead, which would have recognized some medical potential. The DEA did not follow that recommendation. This decision had major consequences. It effectively ended legal therapeutic use and imposed heavy barriers to research. Funding became scarce, regulatory demands increased, and investigators faced institutional and political resistance. At the same time, recreational use continued to rise, so the policy did not eliminate use. Instead, it mainly obstructed scientific and therapeutic exploration. The chapter argues that this history matters because it demonstrates how non-scientific forces delayed the development of potentially helpful treatments for decades. That theme is especially relevant in conversations about the politics of drug policy and the ethics of restricting research. One striking part of the chapter is the discussion of underground therapy. After MDMA became illegal, many therapists in the United States and Europe reported continuing to use it secretly with patients. The estimate cited is more than 60,000 patients treated underground between 1985 and 2017. The authors interpret this as evidence that many trained clinicians found something compelling enough in MDMA-assisted therapy to risk professional and legal consequences. Of course, underground practice raises major ethical, legal, and quality control concerns, but the sheer persistence of this work suggests that clinicians and patients experience something they regarded as profoundly meaningful or effective. The chapter also points to Switzerland as an exception, where some psychiatrists were allowed to use MDMA and LSD therapeutically for a period of time. Although formal research was not conducted there, a good safety record and generally positive follow-up reports were described. This international piece reminds us that regulatory responses are socially constructed rather than inevitable. The chapter emphasizes that MDMA is often grouped with psychedelics, but it differs from classic psychedelics like psilocybin or LSD in important ways. It rarely causes hallucinations or visions and is typically less disorienting. People are often more able to speak, reflect, and engage relationally while under its effects. Terms like empathogen or entactogen are used because MDMA often appears to increase empathy for self and others and to enhance inward awareness. Earlier therapists described it as reducing defensiveness and fear of emotional injury, which may make it easier for people to examine painful experiences calmly and compassionately. At the same time, the chapter avoids romanticizing the experience, particularly with people with severe PTSD. The onset can include anxiety, fears of loss of control, or painful trauma processing. Several participants reportedly said they did not understand why the drug was called ecstasy because their sessions involved deeply difficult emotional work. So the subjective effects are often supportive of therapy, but they are not necessarily easy or purely pleasurable. Neurophysiologically, MDMA affects multiple neurotransmitter systems, especially serotonin. It stimulates release and inhibits reuptake of serotonin, dopamine, and norepinephrine, with particularly potent serotonergic serotonin. Uh, serotonin. Anyway, hopefully you're laughing along with me a little bit. Um, it affects the serotonin neurotransmitters. The chapter also notes changes in oxytocin and vasopressin, which may be relevant to interpersonal trust and bonding, although the exact role of oxytocin remains uncertain. These changes may help explain why patients sometimes feel safer, less defended, and more able to connect with therapists. The author suggests that MDMA may reduce reactivity in threatening cues and improve the therapeutic alliance, especially for patients with PTSD who are often hypervigilant and distrustful. The chapter also connects these effects to the concept of the window of tolerance or optimal arousal zone. So, if you have not taken your trauma class yet at Alliant, these concepts may feel unfamiliar, but if you have, these are concepts that are taught, hopefully, in that class for you in your trauma and crisis intervention course. In other words, MDMA may help people engage difficult material without becoming overwhelmed or shut down. That idea is clinically significant because trauma treatment so often depends on helping people stay emotionally engaged without dissociating or flooding. The neuroimaging findings reviewed in the chapter are particularly interesting because they map onto the therapeutic observations in a compelling way. Studies found decreased cerebral blood flow in regions like the amygdala and hippocampus, which are heavily implicated in fear and trauma responses, and increased blood flow in prefrontal regions associated with reflection and regulation. Clinically, this fits with reports that participants can revisit traumatic memories without being completely overtaken by fear. They may remain cognitively clear and emotionally engaged at the same time. That is a rare and valuable therapeutic state. The authors also discussed decreases in connectivity patterns associated with rigid, constrained thinking. They use the analogy of sled tracks in snow. Habitual thought patterns deepen over time, and MDMA may temporarily flatten the snow, allowing new routes to be explored. For trauma survivors who are stuck in entrenched shame, fear, or self-blame, this image captures why MDMA may facilitate profound perspective shifts. Although the chapter is optimistic about MDMA's therapeutic potential, it takes medical risk seriously. MDMA has reliable symptopathomimetic effects, including elevated heart rate and blood pressure. In phase 2 trials, some participants reached quite high blood pressure or heart rate values, but these returned to baseline without medical intervention. That happened one time in our study as well with psilocybin. The key point is that these studies used carefully screened participants in highly controlled environments. People with known cardiovascular or cerebrovascular disease were excluded, and some participants with controlled hypertension underwent additional cardiac screening. This means we cannot generalize the safety data to unscreened populations or uncontrolled settings. The chapter also discusses thermoregulatory and osmoregulatory risks, including the rare but serious complications seen in non-clinical ecstasy use, such as hyperthermia, rhabdomyolysis, and hyponatremia, hyponatremia. These risks underline why clinical use must include careful medication review, medical screening, purity control, hydration monitoring, and professional oversight. A major issue in the MDMA literature has been the question of chronic neurotoxicity. Some animal studies using repeated or high doses found changes in serotonin systems, and these findings fueled serious concern. However, the chapter argues that many of those dosing regimens are not comparable to the limited spaced doses used in clinical treatment. Studies of recreational ecstasy users are also difficult to interpret because of multiple confounds. Purity is unknown, polydrug use is common, and pre-morbid functioning is often not available. So, although some studies have suggested memory or cognitive concerns, the field has struggled to determine what can truly be attributed to MDMA itself. In contrast, Controlled clinical trials have not shown significant pre-post declines in neuropsychological testing. The authors therefore suggest that while uncertainty remains regarding heavy repeated non-clinical use, the risk profile of limited therapeutic dosing appears much more favorable. This distinction between recreational patterns of use and clinical protocols is crucial for anyone training in this to understand. The clinical heart of the chapter is the phase 2 research on PTSD. Across multiple sites and countries, participants underwent extensive screening, several preparatory psychotherapy sessions, 2 or 3 long MDMA-assisted sessions, and multiple integration sessions afterward. The pooled phase 2 data showed a large between-group effect size, and many participants maintained gains over time. The chapter highlights that this approach appeared effective for very different trauma populations, including survivors of interpersonal violence and military veterans, firefighters, and police officers with service-related trauma. The structure of treatment is important. This was not a quick medication visit model. Participants worked closely with therapists before, during, and after dosing sessions. The design reflects the underlying theory that the medication opens a therapeutic process, but preparation and integration are essential to making that process safe and effective. Although PTSD is the main focus, the chapter also discusses broader possibilities. Secondary measures in PTSD studies suggested improvements in depression, sleep, and some personality dimensions, including increased openness and decreased neuroticism in some trials. These findings are intriguing because they suggest the effects may extend beyond a narrow reduction in trauma symptoms. The pilot studies are also especially relevant for this course. One study found promising results for social anxiety in autistic adults. Another examined anxiety associated with life-threatening illness. Perhaps most relevant from a relational perspective, another study embedded MDMA-assisted sessions with cognitive behavioral conjoint therapy for couples, the next article that we'll cover, in which one partner had PTSD. That conjoint work is particularly important for this course's themes, because it suggests MDMA may help facilitate empathy, communication, and emotional engagement with relational treatment. It opens interesting possibilities for systemic and couple-based applications, even though the evidence remains preliminary. The chapter provides a rich description of the therapeutic model used in MAPS sponsored trials. Sessions are typically conducted by 2 co-therapists in a comfortable, aesthetically supportive room. Participants often spend parts of the session lying down with eye shades and music, turning inward, and then alternate that with periods of talking to the therapist. The therapeutic stance is one of the most important aspects of the model. The authors described it as relatively non-directive, or more precisely, inner-directed. That means therapists trust the participant's unfolding process rather than imposing a rigid agenda. The goal is not to steer the person towards some predetermined insight, but to support whatever arises as potentially meaningful and healing. This is a sophisticated stance, not a passive one. Therapists remain deeply engaged, attuned, and responsive, but they try to avoid over-directing the session. The authors repeatedly return to the idea that healing is mediated through the participant's own innate healing intelligence, not through therapist control. The author suggests several overlapping therapeutic mechanisms. First, MDMA appears to reduce fear and defensiveness, which may help participants approach traumatic memories they would otherwise avoid. Second, it often increases empathy, self-compassion, and trust, all of which can improve the therapeutic alliance. Third, it may allow participants to feel painful emotions without being overwhelmed by them. This is central to trauma work. The goal is not emotional numbness, but tolerable engagement. Participants often described being able to feel fear, grief, and sadness while also sensing safety, connection, and perspective. The chapter also emphasizes that healing in these sessions is not limited to verbal trauma narration. Participants may have relational, spiritual, imaginal, or somatic experiences that feel deeply therapeutic. Some report profound connection, secure attachment, or mystical type states. The authors do not reduce these to a single mechanism, which is part of what makes the chapter intellectually and clinically rich. Preparation and integration are presented as absolutely essential, not optional add-ons. During preparation, therapists help participants understand what the medicine may and may not do, discuss the inner-directed format, establish boundaries, and prepare for the possibility that symptoms may temporarily intensify as deeper material emerges. Participants are encouraged to approach the experience with openness and curiosity rather than trying to control it or avoid painful feelings. That orientation is important because much of the therapeutic value seems to come from turning inward rather than away from difficult internal material. Integration is equally central. The chapter stresses that the real therapeutic process continues long after the acute drug effects end. Integration sessions help participants make sense of insight, manage emerging difficulties, and translate shifts into daily life and relationships. This is also where therapists need to remain vigilant about shame, relational disruption, destabilization, or suicidality. So the treatment model is best understood as a process, not an event. One of the most helpful parts of the chapter pedagogically is the way it compares MDMA-assisted psychotherapy to more familiar therapeutic approaches. The authors argue that although some elements are highly unusual, much of what occurs would be recognizable to many therapists. For example, participants often spontaneously engage in imaginal exposure by revisiting trauma in vivid detail. They also often show spontaneous cognitive restructuring, saying things that they had never thought before about themselves, their trauma, or their relationships. There may also be strong transference material, attachment repair, parts work, and somatic processing. This makes MDMA-assisted psychotherapy difficult to classify neatly within one theoretical school. Instead, it may be better understood as a state-dependent therapeutic context in which mechanisms recognized across multiple models can emerge more spontaneously and perhaps more efficiently. That makes it both integrative and challenging for traditional theory categories. The chapter is careful to note the methodological complexities of this research. A major issue is blinding, as we've always talked about. Because MDMA has noticeable subjective effects, participants and therapists often correctly guess who received the active drug. The studies therefore rely heavily on blinded independent raters for outcome assessments. Another challenge is that no ideal active comparator has emerged. Doses low enough to preserve blinding may not work, and some low doses may actually increase anxiety and interfere with therapy. This makes trial design unusually difficult. The chapter also underscores that the scientific record has been shaped by politics. Research delays, institutional resistance, and even the influence of faulty or politicized neurotoxicity claims all affected the field. So y'all should understand that the current evidence base reflects not only scientific progress, but also a long history of social obstruction. The chapter makes clear that, if approved, MDMA would not simply be prescribed like a standard outpatient medication. The authors anticipate a REMS structure requiring specialized therapist certification, certified clinics, defined screening procedures, and tightly controlled dispensing. MAPS has already developed a multi-part therapist training process that includes online learning, in-person training, role play, supervision, and in some cases, firsthand participation in a research-based MDMA session. The idea is that altered state therapy requires distinct competencies beyond general psychotherapy training. This has important implications for professional identity and scope of practice. If these treatments become more available, clinicians will need not only trauma skills, but also expertise in setting, ethics, boundaries, somatic and relational attunement, crisis management, and integration work. At a broader level, this chapter matters because it challenges some of the core divisions in mainstream mental health treatment. It questions the separation between medication and psychotherapy, suggesting instead that pharmacology may sometimes create conditions that deepen psychotherapeutic work. It also raises questions about what healing actually is. The outcomes described are not limited to simple symptom suppression. Participants often report forgiveness, self-compassion, reconnection, spiritual insight, emotional range, and new relational capacities. These outcomes invite us to think of treatment as involving transformation, not just management. So for this class, this is where the chapter becomes especially rich. It pushes us to think about trauma, consciousness, attachment, and the psyche in more expansive ways. Even if one remains cautious about the evidence, it is hard to ignore how much this work destabilizes narrow biomedical assumptions. So to conclude, the chapter presents MDMA-assisted psychotherapy as one of the most promising developments in trauma treatment in recent decades. The strongest evidence currently centers on PTSD, though early work suggests possible relevance for other conditions as well. The treatment is best understood as a relational, process-oriented intervention in which the medicine, the therapeutic method, and the therapist-participant relationship all matter. Preparation and integration are not secondary, they are part of the treatment itself. Finally, the chapter suggests that MDMA may represent more than a new drug. It may signal a broader paradigm shift toward models of mental health treatment that honor biology, relationship, subjective experience, and the person's own healing capacity all at once. Okay, so I made a mistake when I said, I talked earlier about the MDMA treatment for couples. We'll be covering that next week. So we will be looking at that study by Wagner and her team up in Canada. So here's our article for the week. It's MDMA-assisted therapy for moderate to severe PTSD, randomized placebo-controlled phase 3 trial. So this article represents one of the most important modern studies in psychedelic research, a confirmatory phase 3 randomized controlled trial evaluating MDMA-assisted therapy for PTSD. Phase 3 trials represent the final stage of clinical testing before a treatment can be submitted for regulatory approval. The study compared MDMA-assisted therapy with an identical therapy protocol that used placebo instead of MDMA. The goal was to determine whether adding MDMA significantly improved outcomes beyond psychotherapy alone. This work is particularly important because earlier phase 2 trials had already shown promising results. Phase 3 trials are designed to replicate those findings in larger, more diverse populations under stricter regulatory oversight. In many ways, this paper represents the culmination of more than 3 decades of work attempting to scientifically evaluate MDMA-assisted psychotherapy. Post-traumatic stress disorder is a major public health concern. The article notes that roughly 5% of the US population experiences PTSD in a given year. For many individuals, PTSD becomes chronic and deeply disabling. Current treatments include trauma-focused psychotherapy, such as prolonged exposure and cognitive processing therapy, as well as medications like SSRIs, selective serotonin reuptake inhibitors. While these approaches are effective for some people, a large portion of patients either fail to respond adequately or discontinue treatment prematurely. This treatment gap is one of the primary motivations behind the exploration of MDMA-assisted therapy. Researchers are asking whether pharmacologically facilitated psychotherapy might help patients who struggle to benefit from existing interventions. The study used a randomized double-blind design across multiple clinical sites. Participants were randomly assigned either to receive MDMA-assisted therapy or to receive identical psychotherapy sessions with a placebo. Importantly, outcome measures were assessed by independent raters who were blinded to treatment condition. These assessors conducted standardized PTSD evaluations using structured diagnostic interviews. Blinding is particularly challenging in psychedelic research because the subjective effects of these substances are often obvious. To mitigate this issue, the study used blinded assessors and procedures designed to prevent participants from revealing their treatment condition. This design helped strengthen the internal validity of the findings. The study included 104 participants with moderate to severe PTSD. Approximately 3/4 of the sample met criteria for severe PTSD, indicating that the study population had substantial clinical impairment. The authors also highlight the ethno-racial diversity of the sample, which is notable because psychedelic research historically has been criticized for including predominantly white populations. Approximately half of the participants identified as belonging to racial or ethnic minority groups. This diversity strengthens the relevance of the findings and represents a deliberate effort by researchers to broaden participation in psychedelic clinical trials. The treatment model used in this study closely followed the MAPS MDMA-assisted therapy manual. Participants first completed 3 preparatory therapy sessions with a 2-person therapy team. After preparation, participants entered the treatment phase, which included 3 extended dosing sessions. Each dosing session lasted approximately 8 hours and occurred about 1 month apart. Following each dosing session, participants attended 3 integration sessions to help them process and understand their experiences. This structure highlights a critical point. The treatment is not simply a drug administration. It is a structured psychotherapy protocol in which the medication is embedded within preparation and integration work. The dosing protocol used in this study reflects prior research. Participants received an initial dose followed by a supplemental half dose approximately 1.5 to 2 hours later. During the first session, the initial dose was 80 milligrams, followed by a 40 milligram booster. In later sessions, the dose increased to 120 milligrams and a 60 milligram booster if appropriate. This split dose design is intended to extend the therapeutic window while maintaining safety and tolerability. The primary outcome measure was the clinician-administered PTSD scale for DSM-5 or CAPS-5. This is widely considered the gold standard diagnostic interview for PTSD research. The key secondary outcome was the Sheehan Disability Scale, which measures impairment in daily functioning across areas such as work, family life, and social relationships. Using both symptom severity and functional impairment helps capture a more comprehensive picture of treatment impact. The results showed a statistically significant reduction in PTSD symptoms for participants receiving MDMA-assisted therapy compared to those receiving therapy plus placebo. The average CAPS score decreased by about 23.7 points in the MDMA group compared to about 14.8 points in the placebo group. This corresponds to a medium to large effect of approximately 0.7, indicating a clinically meaningful difference between the groups. Beyond symptom reduction, the study also found improvements in functional impairment. Participants receiving MDMA-assisted therapy showed greater improvement in the Sheehan Disability Scale scores compared to the placebo group. Although the effect size for functional impairment was somewhat similar than the symptom reduction, the findings suggest that the treatment may meaningfully improve participants' ability to function in daily life. This is clinically important because symptom reduction does not always translate into improved functioning. One of the most striking findings in this study is the remission rate. By the end of treatment, over 86% of participants in the MDMA group achieved clinically meaningful improvement. Even more notable, approximately 71% of participants no longer met diagnostic criteria for PTSD at the end of the study. These remission rates are substantially higher than those typically reported in many PTSD treatment studies, which is one reason the findings generated such widespread attention. Safety outcomes were carefully monitored throughout the study. Although some participants experienced transient increases in blood pressure or heart rate, these effects resolved without serious medical complications. 7 participants experienced severe treatment-emergent adverse events, but none were classified as serious adverse events. Overall, the treatment was considered generally well tolerated in this screened clinical population. Because PTSD is strongly associated with suicide risk, the study carefully monitored suicidal ideation using the Columbia Suicide Severity Rating Scale, or the CSSRS. Some participants did experience episodes of suicidal ideation during the study, but overall rates never exceeded baseline levels in either treatment group. This finding suggests that the treatment did not appear to increase overall suicide risk within the study population. Although the trial was designed primarily to test efficacy rather than mechanisms, the authors discuss several possible pathways through which MDMA-assisted therapy may produce therapeutic change. MDMA appears to reduce fear responses and increase emotional openness, potentially allowing participants to revisit traumatic memories without becoming overwhelmed. It may also strengthen the therapeutic alliance and facilitate self-compassion, both of which are thought to be important mechanisms in trauma recovery. Despite promising findings, the study has several limitations. Blinding remains a challenge because the subjective effects of MDMA are difficult to conceal. Additionally, the study evaluated outcomes only about 2 months after the final treatment session, meaning longer-term durability of effects remains an important research question. Finally, the study excluded participants with certain high-risk conditions, which means the findings cannot necessarily be generalized to all PTSD populations. If the results continue to hold across further studies and regulatory review, MDMA-assisted therapy could represent a significant shift in trauma treatment. However, the treatment model requires extensive therapist training, long treatment sessions, and specialized clinical settings. This means that even if approved, implementation will likely be gradual and carefully regulated. Finally, so to summarize, the phase 3 trial provides strong evidence that MDMA-assisted therapy can significantly reduce PTSD symptoms and improve functioning in people with moderate to severe PTSD. Some participants achieved remission, and the treatment was generally well tolerated when administered in a carefully controlled clinical context. These findings mark a major milestone in psychedelic science and may have substantial implications for the future of trauma treatment. And that's all I got for you, y'all.